Hello everybody. I'm Dr. Sheila Neogi. I've been a GP in Pimlico in Westminster for the last 23 years. When I started off, there were 2 full-time doctors. I had 2,500 patients. Anybody who turned up before 1 p.m. would get seen, even if they had to wait 3 hours. We weren't open at weekends. We weren't open at the evening. But I knew everybody. I knew everybody in my patch, and they knew me. Rolling on forwards 20 years, I now have 15,500 patients. I have 8 part-time GPs, a plethora of other clinicians. We are open 8 till 8, 7 days a week. There is email access, telephone access, walk-in access, video access. But I still am not reaching my most vulnerable patients. I jumped at the opportunity when I was asked to pilot the community health worker program. I have lost my eyes and ears of my local practice, of my local patch, and therefore this program gave me an opportunity to re-engage with that, despite the massive increase in workload, which you've all are very familiar with, the problem in recruiting new clinicians in central London. And I'd like to introduce you now to Maureen, who will tell you a little bit about what she does and how she's supporting my community.
Hello, I'm Maureen. I'm one of the community health workers. There's currently 4 of us, and I'm one of them, and we're working at Churchill Gardens. The community health worker model originally came from Brazil, and due to the success it had over there, they brought it over here for trial. On average, the community health worker, which we are now called community health and well-being workers, visit around 130 residents each. So that's 130 residents per community health worker. We visit the residents once a month on a whole life cycle. Through partners with GPs, we each are assigned a patch in which we are responsible for and support all eligible residents. We do this by knocking on doors, calling, texting, and by doing this, we're connecting with people that are present in the community. Due to clinical workload, it is impossible for clinicians to visit residents in their home to get to know them. So community health workers provide an insight to the families for a more holistic view. There is no prior identifications of residents who will receive a community health worker. The model work of basis is based on is not based on any, there's no specific needs for somebody for us to see them. So you don't have to have an illness or be any age or have a reason for us. We see everybody. And in doing this, I myself, being a community health worker, I tend to reach people that maybe don't reach that circle. Like maybe there's a young male who feels like he doesn't need to see the GP, even though he does need to see the GP. And I have found that when I've done the visits. And doing this, because I go to their homes and talk to them personally, see them once a month, I do tend to find things that they should actually go to the GP about. So in my role, I'd give them like a slight nudge saying, oh, maybe you should go to the GP, go check it out. And most of the times they have gone to the GP. The primary purpose of support is to talk to the people about their health and well-being, making connections, improving understanding and accessibility, and enabling informed decisions for the people on their health and well-being. One of my roles as a community health and well-being worker is to encourage, promote, and educate residents on things like smears, immunizations, and vaccines. We work closely with other services like housing, family services, community champions, etc. It's very broad. It all depends on what the residents need. Community health and well-being workers fill a unique role in the community. We ourselves are a part of the community, so we understand it, and we've lived in that area, so we know most things that happen in that area and things that people are in need of. Most of the times we become the first point of contact, so myself, most of my residents would contact me first before they contact the GP to ask, do you think this, this, and this, or where can I find this information? Who can I talk to? Do you know something to do with the housing? We've built very strong relationships with the community, and the residents feel like they can really trust us. I really believe in this project, and I have seen firsthand the impact I have had on my residents by me just being there. I have different ages, so we have the older ones, younger ones, and the in-betweens. I have my older residents who just enjoy me coming and talking to them about what's happening in the community, if there's a new group in the community, and having a simple conversation. And it's made their day a bit more happier. So I feel like we're becoming like pillars of the community. This project is something that I'm really passionate about. And I was saying to Dr. Neogi, when 23 years ago, if I had somebody like me, I would have been very happy. Thank you.
I would say also, as a clinician, the community health workers have an enormous role. We can no longer be the village GP. The workload is too great. I speak to 50 people a day now. And that's just not tenable to also get to know all your patients. My community health workers are my ears and eyes in the community. They alert me to people who may need more support. There is a 30% churn of population, so registered lists are impossible to go on. Having place-based care where people go knocking on doors helps us identify new people who've moved into the area, connecting them with local resources, local voluntary services, and other things which can help in people's well-being. I implore you to all think about how you could roll out this model, as it would just make everyone's life so much better.